Next talk will be by Dr. Smita ma'am, my own mentor. She's working as the professor in Government Medical College Thrissur, and she will be speaking about the topic IOP is normal, whether my patient is progressing or not. Because usually we see so many patients in our OPD, we see the IOP is always normal, but still the patient is seen progressing. So we'll see what Madam has have to tell us. Welcome to you, Madam.
Thank you, Dr. Janie. Good afternoon, ladies and gentlemen. The dilemma is the IOP is normal. Is my patient progressing? So, this brings forth three questions in my mind. Does my patient really have normal tension glaucoma? Has the IOP been recorded correctly? And if the patient has normal tension glaucoma and the IOP has been recorded correctly, is the patient progressing? So let us come to the first question. Does my patient really have normal tension glaucoma? I shall be presenting a few case scenarios and we will discuss about them. So this is a 45 years old female with no family history of glaucoma. Her best corrected visual acuity is 6.6 and 6.9 with IOP of 16 and 17 with central corneal thickness of 534 and 539. There is a 0.5 cup in the right eye and 0.7 cup in the left eye. And the fields satisfy one Anderson's criterion each. So is this normal tension glaucoma? Well, I did a gonioscopy in a semi-dark room with a 1 to 2 millimeter beam not falling on the pupil, and I found that this corneal wedge lies behind the iris. So this is actually a patient of angle closure glaucoma, and therefore performing a gonioscopy is very important to rule out the normal tension glaucoma as well as a primary angle closure glaucoma. Now this is another patient, a 28 years old female with no family history of glaucoma. Vision is 6.6 in both eyes and her IOP is 18 in both eyes. Central corneal thickness is normal. So this time a gonioscopy has been performed and the angles are found to be open. She has a 0.7 cup in the right eye with a corresponding inferior arcuate scotoma and a 0.6 cup in the left eye with a nasal step. So is this normal tension glaucoma? So well, upon close questioning, this lady revealed that she uses a fairness cream, and we know that any cream which contains steroids when used in the periocular region is very likely to cause raised intraocular pressure. So this cream contains mometasone furoate and therefore it is very likely to cause, so this is a patient of steroid-induced glaucoma. This is the office diurnal of a third patient, and you can notice that most of the values are within the normal intraocular pressure range. So is this normal tension glaucoma? So well, we know that a significant percentage of people have raised intraocular pressure early morning before they wake up. So performing a 24-hour facing or diurnal test is important, and it is also important that we record the 24-hour blood pressure to rule out hypotension, nocturnal hypotension, and also systemic hypertension, which are important correlates with normal tension glaucoma. And finally, I have another patient who is a 34 years old female who has the same amount of cupping of 0.8 in both eyes. Intraocular pressures are 17. She has normal fields, but OCT in the left eye shows preperimetric changes, as you can see. And actually, it shows preperimetric changes in both eyes. So is this normal tension glaucoma? So well, when central corneal thickness was measured in this patient, it was found that she has very thin cornea, and this makes us falsely complacent, thinking that the intraocular pressure is normal. So these are some of the very common scenarios where we can confuse normal tension glaucoma with other entities. Most of the time, the etiology of normal tension glaucoma is thought to be vascular dysregulation. Therefore, a meticulous history taking of the patient and also with the spouse of the patient is important. With the patient, we should ask about the history of migraine with visual aura, We should also ask about the history of shock, or if the patient had to be hospitalized and needed a large blood transfusion, or any surgery where again there was a need for large blood transfusion, and if the patient performs yoga where the head is below the heart. We know that it not only the Shirshasana, but there are plenty of other asanas which, if held for sufficient amount of time, can cause this kind of situation which is conducive for normal tension glaucoma. With the spouse, we can ask about history of cold, clammy hands, which indicates Raynaud's phenomena. We can ask about obstructive sleep apnea, which is shown by the snoring pattern of sleeping. There is another very interesting theory which is about the translamina cribrosa pressure differential. Most of you would be familiar with that, but I just want to reiterate that in a normal optic disc, there is a very delicate balance between the normal intraocular pressure and the cerebrospinal fluid pressure. This pressure differential in the glaucoma patient, where the intraocular pressure is high and the cerebrospinal fluid pressure is normal, causes the cupping of the optic disc. On the other hand, when the cerebrospinal fluid pressure is high with a normal intraocular pressure, it causes a mushrooming of the optic disc, and that's because of the translamina cribrosa pressure differential. In a patient with normal tension glaucoma, where the intraocular pressure is normal, and if the CSF pressure is low, it can cause a differential causing the cupping of the optic disc. So the Central India Eye Study has shown that middle-aged, tall, thin females can present with cupping of the optic disc. These people have a very low body mass index and they have normal tension glaucoma. These are like tall, thin, low body mass index, low waist circumference, that kind of people. So again, Dr. Jaini has talked very beautifully about neuroimaging, the need for neurological conditions to be ruled out, and I'm not going to describe them in detail. Again, multiple anatomical conditions which have been described before. This is an optic disc pit which can mimic glaucoma with a normal intraocular pressure. As far as to know whether the intraocular pressure has been recorded correctly or not, well, we have to perform a good applanation tonometry. This portion I'm not going to describe. Let us describe about whether the patient is progressing despite a normal intraocular pressure. Now, all of you would be familiar with this graph, which shows the changes in the visual field, in the optic disc cupping, and in the RNFL thickness with time. So this is actually demonstrating the structure and function correlation with glaucoma with respect to time. As far as structural progression is concerned, we can detect structural progression with the OCT RNFL, which is most commonly used. This is the picture of the OCT RNFL which we use commonly. However, we can also take an OCT of the optic disc and an OCT of the macula, which can tell us about the RNFL thickness at the macula and also the GCIPL and GCC thickness. A short-term average circumpapillary RNFL change of 4 to 5 micrometer or a sector change of 7 to 8 micrometers is suspicious of glaucoma, especially when the age-related thinning is only 0.2 to 0.5 micrometer per year. So when we are taking an OCT to follow up a patient for progression, it is important that we should be aware about the artifacts. This is a study done by one of my postgraduate students, Dr. Gopika, who showed that there are multiple artifacts, especially the important six are the poor signal strength, decentration, abnormalities straddling the measuring ring, segmentation errors, and the green and red disease. As far as functional progression is concerned, visual fields and then the event-based and trend-based analysis are important in assessing the functional progression. Again, in normal tension glaucoma, an excellent study was conducted by one of my PGs, Dr. Devi Karthia, who showed that there is a definite neurocognitive decline, and this in patients with normal tension glaucoma. And this was shown by using the Montreal Cognition Assessment Questionnaire. So it becomes very difficult to consider the fields for normal tension glaucoma progression. in mild glaucoma, there is not only there is a pre-perimetric glaucoma, which is what we commonly hear, there is also a perimetric progression, which was endorsed by the World Glaucoma Association. So here we have to look for progression in green, meaning that all the sectors would appear green, and so we have to look at the actual values of the RNFL and then follow it up. An inter-eye difference of more than 9 micrometer is statistically significant for glaucoma, and we can combine it with the GCIPL measurement at macula to make a decision. Functional progression in mild glaucoma can be from new enlarging and persistently deepening defects. Moderate glaucoma, we can use event and trend-based analysis, but in early moderate glaucoma, the neuroretinal rim thickness has to become significantly lesser before a visual field change is detected. And then there is a tipping point, which is actually 1/3 of the normal thickness, when the visual field changes become very apparent and which rapidly progresses. So this is called the broken stick model of asymmetric progression of moderate glaucoma. In advanced glaucoma, there is floor effect, and so OCT RNFL is not useful. So we can use the GCIPL as Dr. Jayashree has described in her myopia descriptions. Fields, we can use the 10-2, we can use the size 5 target, we can use the macular progression, and finally we can also use the kinetic perimetry. And finally, I want to tell you about a beautiful study done by one of my then PG, Dr. Neetu Pradeep, who said that in advanced glaucoma, patients are simply not good at evaluating their own functional ability. Therefore, patients with severe disease of the same nature may have more variation when they are asked to tell about their performance through a questionnaire. So finally, I conclude by saying that structural testing, functional testing, and IOP measurement are important in assessing the progression of glaucoma, especially when the intraocular pressure is normal. But the clinical experience of the treating ophthalmologist and each patient's specific clinical context is important before we make a decision about progression. Thank you very much for your kind attention.
Thank you, Smita ma'am, for enlightening us that there are many other aspects while treating a normal tension glaucoma patient. Thank you, ma'am.